With our case stem, a 44-year-old woman with a history of SLE presents to the hospital with a blood pressure of 210/108 and proteinuria that was found on a outpatient UA. A 24-hour urine sample reveals nephrotic range proteinuria. Room is consulted and recommends a kidney biopsy, which reveals lupus nephritis. Patient started on cyclophosphamide and prednisone 40 daily. Rheumatology wants these meds continued until the patient is seen for outpatient follow-up in 3 to 4 weeks. She takes no other meds and is otherwise healthy. She has tolerated steroids for 48 hours with no adverse effects, and she's negative for HIV. What other meds should the patient be placed upon prior to discharge? Give you a minute. The answer may surprise you, as it would have for me before doing this talk. So the answer is both B and C, and we'll talk about why. So just a quick overview of the various myriad of side effects that are associated with steroids, which I think have been talked about a few times in Fast Facts Fridays now. We're actually going to focus on the top 3 because these are the organ systems or associated side effects that are typically treated with pharmacologic, like prophylaxis or prevention, when a patient is started on high-dose long-term steroids. HPA axis suppression to some extent is treated before you actually have, an actual adverse effect. But this is typically in the context of preoperative evaluation when a patient's about to undergo some physiologic stress, which is out of the scope of this talk. So we'll talk about bones, lungs, and the GI system. So first of all, the question here, I think, that I was always asked as a trainee is what constitutes long-term or high-dose steroid use? And I was asked this a lot in the context of how do you know when to pull the trigger on pharmacologically prophylaxing someone for those side effects? The answer actually isn't clear, and it actually depends on why you're asking. It depends on which side effect that you're trying to address. So we'll go through each of those side effects now. So for the lungs, typically we worry about prevention of PJP, pneumocystis pneumonia. So what we do know, and I'm just going to give, because there's actually a lot of literature for each of these adverse effects that we typically pharmacologically prophylax against. So I'm going to just do a very broad overview of what the literature tells us, what the recommendation is, and what we still don't know based on the literature that's out there. So what we do know about PJP is that it is potentially lethal and it is preventable, typically through Bactrim prophylaxis. We do know that the risk of PJP increases in a very much dose-dependent manner. The higher your dose of prednisone or its equivalent, the higher your risk. And we also know that certain immunocompromised states and issues with lung architecture increase your risk of PJP. What the literature still doesn't tell us is in otherwise immunocompetent patients, so they're on steroids, but they don't have any other reason to be immunocompromised, do the benefits outweigh the risks for Bactrim prophylaxis? And also, is there a specific cutoff where it's safe to stop PJP prophylaxis? So the overarching recommendation here is that anyone who's taking Pred 20 or more daily for more than 4 weeks should generally be considered for PJP prophylaxis. That leaves out a lot of different factors. Again, there are certain immunocompromised states that increase your risk more than others, things like leukemia, things like vasculitides that affect the lungs, like GPA, where you might want to consider starting prophylaxis at an even lower dose than this suggestion. But this is the suggestion that's given out by the ATS. For PUD, what the literature does tell us is that glucocorticoids undoubtedly decrease your gastric pH, and NSAIDs increase your risk even more. But actually, the literature shows that if you don't take NSAIDs with steroids, glucocorticoids actually probably don't cause PUD. And this is the thing that surprised me the most in doing this talk. We don't know if the PPI, the benefits of PPIs outweigh the risks, because while there are side effects for PPIs, the data is still kind of a little bit shaky. So actually the recommendation here is that PPI prophylaxis shouldn't be started unless a patient actually has specific PUD risk factors, prior GI bleed, prior history of PUD, prior history of H. pylori, that sort of thing, or if they have really severe dyspepsia symptoms. And finally, osteoporosis. Actually, this has the most data, and it's probably the thing we do the least when we start patients on steroids. So even low doses of steroids can increase your fracture risk, and it occurs very early in the course, within the first 3 to 6 months of steroids, and bisphosphonates are very much effective for prevention. We still don't know if prophylactic calcium and vitamin D actually slow the reduction in bone mineral density with steroid use, But nonetheless, the recommendation actually is to start calcium and vitamin D because it's such a low risk intervention, and to start it with a baseline DEXA scan when you start steroids. So this was a quick flow chart that I sort of put together just based on the literature that's out there. So when you start steroids in patients who are over 40 for at least 3 months, you should start them on calcium and vitamin D and counsel them on the fracture risk. If they already have a diagnosis of osteoporosis, you should already start a bisphosphonate, which I've actually never done when I start a patient on high-dose steroids. If they don't, then you would obtain a DEXA scan. And if they turn out to have a high risk per DEXA scan and per their clinical fracture risk, you would start one. And if they have a lower intermediate risk, you would only start it if they're taking above a certain threshold. And this is based on the literature that's out there. So for PJP, consider starting in anyone taking more than 20 daily for over 4 weeks. You can also consider their other individual risk factors for PJP. For PUD, you should only start PPI if they have specific PUD risk factors. And even low-dose steroids result in decreased bone mineral density and increased fracture risk within 3 months. So use this flow chart to help you decide whether or not to start bisphosphonates.